On behalf of the World Health Organization and the Monash University Accident Research Centre here in Melbourne, Australia, it is my great honour to welcome you today to this international webinar series on Step Safely, the WHO technical package for preventing and managing falls across the life course. I would like to begin by acknowledging the traditional owners of the land on which I meet with you today, the people of the Kulin Nation, and I pay my respects to their elders past, present and future. I recognise that I'm on the land of a nation that has had a relationship since time immemorial with this land. And I extend my deepest respect to the histories and cultures of all First Nations people from across the world who are joining us today. My name is Aleksandra Natora and I will be your MC for this webinar. I am an Australian public health professional specialising in injury prevention for the past 20 years. And I'm currently doing my final year of PhD studies at MUARC, focusing on the impact of public health policy on falls prevention among older people. I am therefore delighted to open this first of 3 Step Safely webinars that will focus on falls among older people. We will have 4 guest speakers and a panel discussion at the end. So I now introduce Dr. Etienne Krug, Director of the Social Determinants of Health Department of the World Health Organization based in Geneva, Switzerland, to give his warm welcome.
Dear colleagues and friends, welcome to this webinar series on fall prevention, which we at WHO are very happy to co-host with our friends at the Monash University Accident Research Centre in Australia. And the purpose of this webinar is really to discuss falls. Every year, more than 684,000 people die as a result of fall, and an estimated 172 million more are left with short or long-term disability. 2 shocking statistics representing huge amount of human suffering. About 37 million falls are severe enough to require medical attention each year, of course, adding a lot of cost, human and financial, to the health system all over the world. Falls result in more years lived with disability than transport, injury, poisoning, drowning, and burns combined. And of course, the vast majority of fall deaths and injuries occur in low and middle-income countries, adding to a lot of the other burden they're already facing. So falls are a growing and under-recognized public health issue. And many factors indicate that this issue is big today, but is likely to rise, including due to the aging populations as well as to increased urbanizations. The good news is we can prevent falls if we collaborate with individuals, communities, employers, institutions, healthcare professionals, etc., etc. A lot can be done to address falls, and that is what we have really summarized in the Step Safely WHO technical package, which is designed to support practitioners, policymakers, managers, researchers, and advocates to prevent falls. They're focused particularly on the 3 biggest at-risk groups: children and adolescents, workers, and older people. And this is why we have focused this webinar series on those 3 groups. We'll be focusing each of the 3 webinars in the series on one of the high-risk groups. So thanks so much for joining us. Please participate actively and above all, use the information gained to help us implement the Step Safely package in your country and in your region. Thank you so much.
Thank you, Dr. Krug. I now invite Dr. David Neddings, who is scientist leading the WHO's Department for Management of Non-Communicable Diseases, Disability, Violence and Injury Prevention, and is executive editor of the Step Safely technical package, to also welcome you here today.
Well, thanks very much, Aleksandra, and good morning or good afternoon, as the case may be. Welcome all members of the community that are attending this this webinar. As Etienne just said, this particular webinar will cover falls in older people or those over the age of 65, but the series of webinars that we're launching today spans all of the three main risk groups that are addressed in the Step Safely technical package. I'm going to begin with a few words about falls among older people. We probably all know that the risks associated with falling rise related to a number of different processes that are connected with the aging process. So as we age, we develop poorer sense of balance, our mobility tends to reduce, we begin to have problems with visual acuity, with our cognition, and we often are in a situation where, for a variety of reasons, we are being prescribed an increasing number of medications. So all of these factors connect and tie into the increased risk for falls among the older population. Now, globally, just over a third of older people fall at least once per year. And if one looks in nursing homes or facility environments, around 50% of the population will fall more than one time per year. And the consequences following a fall are really huge in terms of physical consequences. We can talk about very serious outcomes such as hip fractures or traumatic brain injury. People can also sustain spine or nerve injury, joint dislocations, serious soft tissue injuries. Those are the physical consequences of a fall, but in the mental and in the social domains, there are also very important consequences of falls among older people that are very important not to overlook. The fear of falling among somebody who has fallen once or several times can be a great driver of a very important degradation in that person's experience of quality of life, which in turn can lead to deeper social isolation from one's community. Now, Step Safely summarizes the evidence around falls prevention and management, and it's fair to say, I think, really, that there is growing evidence of effective interventions to prevent falls among older people, relying on things like improving physical mobility, increasing awareness of medication use, improving the community infrastructure and housing options, and ensuring that appropriate policies and legislations are in place. So some of the strongly recommended interventions within Step Safely include things such as tailored exercise-based programs to increase strength and balance among older people, or age-friendly public spaces that allow older people to remain socially and physically engaged with their community as they age. So very much a healthy part of aging. And as Etienne mentioned in his opening remarks, this really connects with some broader big ticket items in global public health, notably around the aging of populations. So Step Safely advocates that to address falls among older people, falls prevention and management should take a systems approach that strives to create what we have within Step Safely designated into three different domains: the domain of safer people, safer environments, and safer policies and legislation. And across those three domains, to use targeted evidence-based interventions to prevent and manage falls. Now, before I conclude, I'd like to thank all of those involved in the development of the Step Safely technical package. I'd like to thank also those who have prepared the current sessions, our very excellent speakers that we have lined up for you today. And lastly, but not least, all of you who have given some of your time today to join us on today's webinar. So I wish you a great amount of interest and engagement with today's webinar. Please do engage actively and participate actively, and please consider seriously joining the other two webinars which we are having coming up in the near future. Thank you very much.
Thank you, Dr. Meddings. And it is an impressive collaboration that has worked together to put together this technical package for Step Safely. And I congratulate all involved for bringing it to this stage. And now that we are promoting it, it's wonderful to see it. Now I present to you Professor Stuart Newstead, who is Acting Director of the Monash University Accident Research Centre, to also give his welcome.
Thanks, Alex. So on behalf of the Monash University Accident Research Centre, or MUARC as we call it in our colloquialism, I'd definitely like to welcome all the participants to the first of this 3 webinar series focused on the important issue of falls prevention through the Step Safely program. MUARC, as many of you will know, is based at Monash University in Melbourne, Australia, and has around 35 years of history in contributing to injury prevention science and practice in Australia, across our region and globally. MUARC has been, through this period, a very proud WHO collaborating centre. And indeed, MUARC's role as a collaborating centre for the World Health Organization is really central to its contribution to its vision of ultimately seeing an injury-free society. We're not close to being there yet, but with good science, we should be well on the way. As noted, the central role of a World Health Organization collaborating centre is to form part of a collaborative global network to address the key injury challenges at both the regional and the global level. And indeed, I think collaboration is really the key to sharing knowledge and expertise in order to advance the discipline and practice of injury prevention. And through this collaboration, we very much hope we can accelerate the success in injury prevention and be able to get those associated improvements in global health that we all look for. As a university-based research centre, MUARC's primary goal is to produce the highest quality evidence, research evidence around injury prevention. But MUARC as an organisation doesn't stop there. It's really equally important for us to do something that really aligns well with the concept of a WHO collaborating centre, and that's to translate our research outcomes into a practice that makes a difference in the real world. And I think the Step Safely program is a great example of the sort of collaborations having a real world impact. And indeed, this seminar series really falls as an excellent example of the collaboration of the global World Health Organization networks to share knowledge and expertise amongst the collaborating partners joining us today and hopefully across the whole WHO network. As you have heard most eloquently from Dr. Krug and Dr. Meddings, falls in the elderly really remain a serious problem and a growing problem across the globe. And for the elderly, as you've heard, falls are a particular problem as they often result in very serious consequences. As we've heard all too often, these consequences lead to an early end to an otherwise healthy life or a drastic change which dramatically decreases the quality of life for people after a fall. So as such, these are really important issues to address, to look at the problem of falls prevention, to both extend and improve the quality of life of our growing older population across the globe. And I really hope that today's webinar can contribute to the improvements we wish to see and building upon the excellent work that's presented in the Step Safely program. Before we commence with our main speakers, I'd very much like to thank Dr. Krug and Dr. Meddings for their opening remarks. I'd particularly like to thank Caroline Lukaszyk from the WHO Western Pacific region for her support and leadership in getting this webinar series off the ground. But not least, I would definitely like to echo my thanks to those of speakers who are volunteering their time today to present on their important work. And I hope that for all the participants, the webinar today can be of great value and really invigorate efforts across the globe to address the important problem of falls prevention. So thank you, and we launch into the session.
Thank you, Professor Newstead. Before we hear from our 4 guest speakers today, I would just like to highlight a few housekeeping items. I encourage all participants today to introduce yourself via the chat function at the bottom of your screen. As well, please be on mute or have your camera off to save your bandwidth. And also during the presentations, as we proceed, please submit any questions or comments through the Q&A function at the bottom of your screen for our panel discussion to pick up on the questions later in the session. So without further ado, I now welcome our first guest speaker, Professor Kim Delbaere. Professor Delbaere is a Senior Principal Research Scientist at NEURA, which is Neuroscience Research Australia, and Director of Innovation and Translation at the Falls, Balance and Injury Research Centre, supported by the Australian National Health and Medical Research Council, and Professor at the University of New South Wales in Sydney. Kim is also President of the Australia-New Zealand Falls Prevention Society. She graduated in 2001 as a Master in Rehabilitation Sciences and Physiotherapy at the Ghent University in Belgium and completed her PhD in 2005 on falls in older people. In 2006, she moved to Australia to work at NEURA on fear of falling in older people. Kim's research has contributed to the understanding of physical, psychological and cognitive factors causing falls. Her multidisciplinary approach incorporates elements from physiotherapy, psychology, brain imaging, and software engineering. Kim has been successful at developing novel methods of applying technology to healthy aging for over 10 years in both healthy older people and a range of chronic diseases. Thank you, Kim.
Thanks, Alex, for the wonderful introduction. I'll just try and share my screen. Hoping this works. There we go. I hope you can see my full presentation. Thank you very much for offering me the opportunity to speak today at the Step Safely webinar, and thanks for the introduction. My talk will have 2 parts, where I will start by talking a little bit about the fall prevention initiatives that we have in Australia and New Zealand as part of my role as the president of the Australia and New Zealand Fall Prevention Society. And then I will continue on a little bit to talk about my own work. As highlighted in the Step Safely package, there's lots of known strategies that we know that will prevent falls effectively, and exercise, specifically gait, balance and functional training, Tai Chi, is definitely one of the key strategies that we should adopt, in addition to home assessment and many others that you can all read about within this excellent package. And within the society, we have made a strong effort to disseminate knowledge or around new knowledge around falls prevention through our biannual conference, but also through regular education seminars and other resources. And it's something that we really try to continue even through this time where sometimes it's not possible to meet face-to-face through Zoom seminars. The society was started in 2006, and it is very much still thriving. It was initiated by Professor Stephen Lord and continued on by many of us throughout the years. And in New South Wales, we also have a network, the Fall Prevention Healthy Aging Network, that is funded through New South Wales Health. And what we are, it's a network that was established in 1993. And what we are very much trying to do here is to deliver workshops as well as also seminars and conferences to really give as much education on falls prevention as we can. Especially these workshops, like as you can see on the screen here, they were initially targeted to general practitioners, where we were helping health professionals to better manage falls, and it was led by Lindy Clemson. But at the moment, we're really also developing a stronger focus on allied health. So, and that is something that we hope to continue and really share and present lots of benefits to everyone. But in more realistic terms, it definitely has been suggested and recommended that single interventions might be as effective as multiple interventions if we try to deliver them at a public health level. And from that point of view, exercise prescription is really something that we should encourage for everyone. And then we can have those additional interventions as well, if they can't, for risk factors that can't be addressed by exercise alone. And I will just take you through a few case studies now that we see across Australia and New Zealand. I would like to start with our New Zealand colleagues, where we have a very strong network called Live Stronger for Longer. We all know that the world-leading work of Professors John Campbell and Claire Robertson from the University of Otago have led to the Otago Exercise Program, which is the gold standard for in-person falls prevention program, and it's been used across the world in various forms. And New Zealand has continued to invest strategically in the development of prevention, falls prevention, and is seeking to extend this. Is very much still happening and ongoing throughout New Zealand. And across Australia, there are also many different initiatives, as you can see on the map here. Across the states, some initiatives are quite state specific, but then we also have some initiatives that are a little bit more national. As you can see here, just as a brief overview of a representation. But what I would like to do now is to present a little bit more also about the New South Wales initiatives. I am based in Sydney, in New South Wales, and I co-manage the falls prevention network there. And we have a few specific initiatives that I would like to highlight. So here you can see the Active and Healthy website. And what this does, it really offers the opportunity for people to look for exercise programs that have a falls prevention focus on them. They're all listed on the website, and they're very much promoted to community health teams and also general practitioners. And one program that has been promoted more than others, which might be well known to many of us, is the Stepping On program that was developed also by Lindy Clemson. And that is definitely one that is funded and also very much part of our New South Wales falls prevention strategy. But I would like to finish this part of my presentation by saying that all these programs are absolutely excellent, but at the moment we don't really have an effective statewide or national strategy about how to manage falls in the community. As an example, the falls policy was rescinded by the New South Wales Health Ministry in 2016, And as a result, the wonderful falls prevention initiatives that we have developed over the years have somewhat derailed. And we very much hope that the Step Safely package will also help us in Australia and New Zealand to have a broader intergovernment discussion and a renewed commitment for policy direction. The next part of my presentation centers around standing tall, which is something that I've developed over the years together with my team at Neuroscience Research Australia. And what we are trying to do here is we're very much trying to deliver an alternative solution to falls prevention for allied health delivery via novel technology. So what we have done is we have developed an app that is used to deliver exercises to the older person in their home. You can see how it is, how it looks here. It's meant to be convenient, so people can do it in their own home at their own time. It is fully tailored to their own ability, and it progresses at their own pace. We have a huge variety of exercises in there, really targeting to reduce boredom. As we know, it is very important to do the exercises for a very long time. So 2 hours a week is recommended, at least for 6 months, but ideally longer than that. We have fully designed and developed this program together with older people. And I really think that is key to any of the programs that we want people to do, whether it is using technology or group classes or anything. We really need to listen to the consumer to hear what they want to see and how they would like to see the evidence applied for them to use. I'd like to start off by showing our adherence to the program of one study that was published last year in the BMJ, where we we had a group of over 500 people, of which half were using the Standing Tall program, and we asked them to use the program for 2 hours a week over a period of 2 years. And here you can see the median adherence of that entire intervention sample over 2 years. And we're very proud to see that that median was reaching the 2 hours a week all the way to the end. And this really shows that standing tall is not the only option, of course, but that it definitely should be considered as an option to use technology to deliver exercise to older people, because it's very well accepted. When we asked people about their experiences, they really appreciated the flexibility. They very much enjoyed the program, and they felt that it improved their confidence. We already heard about fear of falling and their physical awareness, and that they felt positive about using it as well, and it was clear. When looking at the effectiveness and the cost effectiveness of our program, our primary outcome was at 1 year, which just missed out on significance. But what we did see that was at 2 years, that we had a nice reduction in the rate of falls by 16%, and also a rate reduction by 20% of injurious falls at 2 years. So we did have an effective trial because of the long-term usability of standing tall, of using technology. We have recently also done a cost effectiveness analysis, and I'll be very brief here. It's a paper that is still in preparation, but we hope to get published soon. And the program itself, during the study, we offered 2 home visits to deliver the program, so to set people up, and then a second one to ask questions and to see if everything was clear. We saw in our next trials that was not necessary, and really only one visit is necessary. And we could also do these via telehealth. And then you can see that the cost effectiveness ratio is really reduced dramatically. And we very much think that it is, compared to other home-based exercise, a good value for money. We've got other studies as well that have been published, and you can see the publication reference at the bottom here. This study was led by my colleague Michelle Kalisaya from Tasmania, and she did a 6-month study in people with mild cognitive impairment. And overall, you can see while this study was severely affected by COVID, unfortunately, but we did see an improvement in gait speed in the intervention group after 6 months. We also ran a feasibility study in 15 people with dementia, where we could also clearly see that it was feasible to use the program. The people living with dementia at home, so this was in the community, were very much able to use the program over a short period of 12 weeks without hand-holding necessarily. So even in people with cognitive impairment, we can consider using technology. And as in what's next, we have also completed now a second study where we are focusing on people with a higher risk of falling. We have added dual tasking as well as cognitive behavioral therapy. We're currently analyzing the data, so hold tight for that one. We're running a study in people with fear of falling as well, where we are specifically targeting fear of falling with cognitive behavioral therapy as well as motivational interviewing. This study is planned to finish next year, around the middle of the year. We've also completed an implementation trial where we are where we sought to implement standing tall with health service professionals in New South Wales, in Victoria, and also in the UK. So also for this study, we are looking at the data now, and we hope to write up the paper by the end of the year, where we could really see that it was well adopted by health professionals, and they could really see a use for it in their practice. And in addition to this, we are also running a trial. This is run by a colleague, Professor Ken Butcher, where we are integrating standing tall into a rehab program for stroke. And we are just about to start also a multi-center randomized controlled trial in Aboriginal and Torres Strait Islander people and Maori people, where we are also hoping to look at the effectiveness for standing tall in combination with a mindfulness program. So just overall, standing tall it has a proven effectiveness to prevent falls. We had low attrition rates. It was considered very safe. We haven't had any serious adverse events, but we did have falls during the standing tall exercises, but it was considered minimal, especially in comparison with also 37 other exercise-related falls. So we feel it's definitely something that we need to consider, is to use technology as part of our strategy. Technology acceptance has also increased thanks to maybe COVID-19, because more people have smartphones as well because of the QR code check-ins and other things that are making it easier to have a smartphone in times of isolation. And technology use is rapidly increasing, and there's definitely also potential for using these platforms for other elements of effective fall strategies, and that includes education, but also more advanced technologies like monitoring systems, wearable alarms, medication adherence, and so on. So I think it's a really exciting time, and I'm looking forward to hear and to see where we can take this. Thank you very much.
Thank you, Professor Delbaere. That was a wonderful snapshot of some of the work in Australia. And I do hope and wish you well with the translation and scale up of these very positive results. Now, may I turn your attention to Dr. Duan Lele, from the Chinese Centre for Disease Control and Prevention. Duan Lele is trained as a physician and also holds postgraduate qualifications in public health management and epidemiology. She has worked as a physician for 7 years before starting her position at the China CDC. She is now the Director of the Injury Prevention and Mental Health Division of the National Centre for Chronic and Non-Communicable Disease Control and Prevention in China, CDC. Dr. Duan Lele's major achievements include being involved in establishing the National Injury Surveillance System in China. And she has also organised national injury intervention programs and related research, of which falls prevention among older people is one of priorities. Welcome, Dr. Duan Lele.
Thank you, Alex, for the introduction. Good morning and good afternoon, everyone. I'm happy to have this chance to talk about falls prevention among older adults in China from China CDC. So could you show the slides for me now? Because of the internet, I will close my camera now for saving that. So could you show the slides for me now? Hello. Hello, Caroline.
Yes, coming now. Apologies, one moment.
Okay. I will close my camera. Okay, thank you. So I will talk something about the falls prevention among older adults from China from the perspective of China CDC about the practice on that. So next, please. What's the situation? So at this slide, we can see that China is facing the rapid increase of the proportion of aging people in all the population from the last 10 or 20 years. Next. And from the death surveillance of China, we can see falls is the leading death cause of injury among the elder age 65 and over in China. So falls is the first death leading cause of injury of the older people in China. Next. And at the same time, we can see from the very big sample size field survey of the older people, we can see falls is the leading cause of traumatic fractures of elderly in China. So it's the situation of falls among the older adults in China. It's in one hand. Next, how about in another hand? In one hand is the problem. In another hand, what do we have? We know the major risk factors of the falls of the older age, and also from the package of Step Safely, there's about the environmental, the behavior, the social economic factors, and the biological risk factors. We know that well. Next, and at the same time, we have our international and national and evidence-based elderly falls prevention strategies, such as exercise. I'm talking about one of them is Tai Chi, and environment improvement, and medication management, medical treatment, assistive devices using first aid and rehabilitations. So they are well known that the evidence-based strategies of elderly falls prevention. And next, and in China, what do you have facing the elderly falls problem in China? We have the policies and we have the technical documents to support the elderly falls prevention practices in China. They are the, how to say, they are the technical packages, they are the policies. And at the same time, they are the outputs and of the researchers and the practices of us. And I will talk that later. Next. And even we have the strategies from the last slides. We know that to modify the environment to improve the behavior, to improve the medical management and so on. But in China, we need more evidence to support the strategy development to improve the awareness of the public, especially the elder people, and we need the national level or different level specific action plans to preventing elderly falls, and there should be more research, and the professional working team capacity should be improved, and so on. We did more about that. Next. And I'm from China CDC, yes. Who we are, what's the China CDC's role and mission for falls prevention? We are a national, our center is a national professional institution for NCD and injury prevention and control. It's a national technical instruction center for NCD and injury prevention and control. So the major mission of us is to translate the evidence system, to translate the evidence and practices into policy. So it's the major mission of us. Next. So how about the practices? What's the practices from the perspective of China CDC facing the elderly falls in China to establish the evidence system to support the policy making or to make the policy consultation for facing this problem? So first one is the surveillance. Just as the first two slides, we know that from the different kinds of surveillance, how about the profile of elderly falls in China? What's the major problem? What's the risk factors? And how to evaluate the different kinds of interventions and the strategies and measures? So they are the function or the outputs of surveillance. Next, please. And then the evidence is we will get the result from the intervention programs, from the research. So there are pilot interventions. We got the experience, learned lessons from this kind of intervention programs, focusing on health communication, assessment of the risk of falls, medication management, and so on. They are the pilot intervention programs. They are at the very beginning of our elderly falls prevention process. Maybe began from 2006, 2008. At that time, we are not very familiar with what's the falls prevention at that time in China. Next. And then go to research. First, I will talk about a package, another package from developed by China CDC, by our center. And we developed that package it took us about 3 years to develop that and conduct a community-based study on the effectiveness of this health education or health communication or skill improvement falls prevention package among older adults. There were about 1,000 older people recruited in this research. And there are 3 group-based courses organized or facilitated by the doctors of primary healthcare center, a community health center, and combined with 1 home visit. And all of these 8 activities should be finished within 8 months. Next. And how about the contents of the 7 courses? They will be basic knowledge, information about falls prevention. What's falls? How about the falls problem, and so on. And the balance and strength exercises taught by the doctors or the facilitators. And there will be information and skills transferred by the doctors, how to modify the environment, how to modify the environment in the houses, and how about medication management and safe behaviors such as the footwears and the clothes and so on. So there are 7 major courses about that, and then goes to the result. Next, we can see there are control group and intervention group. We evaluate the result of that. We can see the falls, the times of the falls, number of falls and the fallers. They are significantly different between the 2 groups. And at the right side of the slide, we can see the 2 books. They are the package of this training courses. We call it health education training courses. And they are published by the published house and will be scaled up by China CDC system at different level, China national level, provincial and city and county level, to scale up this manual to conduct falls prevention projects of that. And the next, about Baduanjin. I think some of the audience knows Baduanjin about this research that a very cute bear there. Yes, Baduanjin is a traditional Chinese qigong and a very simple movements or actions in this only 8 movements. A little bit like Tai Chi, but totally different from Tai Chi. Because Tai Chi is demonstrated that it's effective to prevent falls. How about Baduanjin? To improve balance and then to prevent falls? We conduct this research next 5 years ago, and there's about next 1,500 older people involved in this research, half intervention group, half control group. They will practice Baduanjin 3 times a day, 5 days a week, and last 6 months. We can see the difference between the control group and the intervention group of balance function. Significant difference between the 2 groups. Very good result. And it shows that Baduanjin can improve the balance function of the older people. And then hopefully it can prevent falls. So next step, we will go ahead to show that how it can prevent falls of the older people. Next. And its model, they are the research, the last 2 major research of us to show how about the package and how about the Baduanjin can prevent falls there. So now there's designed a model just to be practiced now. How to link the risk of falls, the risk assessment of falls, and the community-based falls prevention programs together, and then how it can be buy-in by the government. So it is a working model. Now we are practicing now. Hopefully we can get a result of that and show it to all of you, how this model can be run, can be buy-in by the government, and then show the result of that. Next, thank you. So, and besides the pilot surveillance, the pilot programs of intervention, the research of that, and the test, the working model of that, we are all involved in media campaign to transfer to put the information and the key message to the public to improve the awareness of the public, especially the adults and their children and their kids. So I think the awareness improvement of the whole public, not only the adults, should be improved, and then can push these activities ahead. Next, thank you. And they are the outputs of our center and what we are involved. Some of them we are involved. Some of them we took the lead of that. The standards, so sorry, they are in Chinese. The standards, the guideline released by the National Health Commission, the working package for the community-based elderly falls prevention, and the reading books for the elderly people and keeps messages released and expressed by the media. We can use that. So and so on. They are the output of all our practices from China CDC. Not all there, but they are the major output of us. And next. So this slide again, we at the left side, they are the policies. We can see that the red hat document, they are very high level documents of the government. And we are involved in the drafting or the policy consultation of the national level policy drafting and the release. And the right hand, they are the technical documents. We also involved in that. So how about the relationship between our practices and the policies? Not directly, but very close. Major items of the policies and the technical documents from the experience are the result or the output of our practices. So how to translate that? I think I cannot say it in one or two sentences. It's a little bit complicated, but we can show that what's the process of that. Next, please. So next step, I think there's one word, collaboration. We will collaborate with other institutions, agencies, schools, and universities, and so on in China and at the regional level and international level to address this major health issue, elderly force prevention. Thank you so much. Thank you. Thank you.
Thank you, Dr. Duan Lele. That was an interesting account of what is happening in China, and it's very encouraging to see that there are national policies guiding your work in China. And I'd be very interested in the chat session and the Q&A if people have any questions about how national directions are implemented at the community level and how that flows through various government and regional levels. Thank you very much. Our next speaker, Dr. Nehal Shah. Dr. Nehal Shah has 25 years of academic and clinical experience in the field of physiotherapy. She presently works as a principal at the SBB College of Physiotherapy in Ahmedabad in India. She is a PhD teacher in physiotherapy with a specialty in orthopedics and electrophysiology. She is a distinguished faculty member of the American Academy of Clinical Electrodiagnosis in the USA and acts as the Joint Secretary, West Zone, of the Indian Association of Physiotherapists, which is the largest physiotherapy association in India. She is also the national head of the research committee for the Indian Association of Physiotherapists. Dr. Shah was a team member in a research project led by the Australia-India Trauma Systems Collaboration, which aimed to reduce the burden of injury in India and Australia through improved systems of care. The project was carried out by the Government of India and the National Trauma Institute of Australia. Dr. Nehal Shah, welcome.
So a very good morning, good afternoon, good evening across the globe. And it's indeed an honor for me to show what we are doing. I'm working at SBB College of Physiotherapy, and we are attached with Sardar Vallabhbhai Patel Hospital, which is a multi-speciality hospital. And the main speciality of our hospital is a dedicated geriatric unit. So we have a dedicated geriatric department, which is, I guess, the first, which is a state-of-an-art kind of department, first in the west zone of India, and to my knowledge, the third in across the country. So it is indeed an honor for me to showcase my hospital and the place where we work. And before that, let us have a tour to the SVP Hospital Geriatric Department. Ahmedabad Sardar Vallabhbhai Patel has recently started a geriatric department. Here, all the aged above the age of 60 years will be given treatment in different branches of medicine like general surgery, cardiology,
neurology, orthopedics, ophthalmology, ENT, psychiatry, and physiotherapy all under one roof at one time. The patient, after registering on the registration desk, will then be allotted an individual patient care attendant who will remain with the patient at all times during the OPD consultation and the whole treatment procedure. If the patient is unable to come on their own with prior appointment, a pickup and drop facility is also available. All the patients will be consulted with experienced doctors. All investigations like blood, urine test, X-ray, sonography, ECG, etc. will be done at the same place. If required, the patient will be referred to the physiotherapy department for aerobics, telemetry, virtual reality, biofeedback system, robotic system, and other pain-relieving modalities. After completing consultation with all the departments, in the end, a comprehensive geriatric assessment committee, including the dietitian, clinical pharmacist, physiotherapist, with a medical faculty as a lead, will decide a comprehensive plan for the patient. They will decide the medicines, diet plan, and exercise plan for all patients. If needed, the patient will be given indoor admission facility in specially designed general ward, HDU, and ICU with surgical and non-surgical packages made available. Other facilities like midday meals, recreational activities, indoor games, physiotherapy exercise, and yoga therapy are also available here. SVP Hospital provides a multidisciplinary treatment for the elderly with all the modern facilities at nominal cost. SVP Hospital is one of the most advanced and modern hospitals of Ahmedabad, providing a complete geriatric care under one roof.
Yeah, so this was a glimpse of the hospital where I work. And we all know that there is a lot of fear of fall as the age advances. The causes may be attributed to previous falls, diabetes mellitus, obesity, depression. If the elderly is using a walking device, the fear of fall increases. Females are more vulnerable to have this fear if they are having some balance impairment, motor and sensory affection. There is an increased chance of fear of fall, pain and degeneration, and proprioceptive deficit, which happens with advancing age, all causes fear of fall. So to address all this, we are addressing it all under one roof, that is SVP Hospital, and let me say, just on the same floor, one floor of the entire hospital. So who all are the stakeholders and how do we work together? So this is the floor, the entire floor is dedicated to the geriatric department, where we have geriatric OPD, where all the specialists sit together. We have a specialized geriatric physiotherapy department, and we have indoor facilities especially for the geriatric people. So this is where we have our OPDs and the physiotherapy department. This is how our OPD looks like. So under just one roof, all the specialized OPDs are there. The patient does not have to move here and there for any kind of consultations. We are basically offering the health checkup program. So we want to work on prevention. And if needed, we want to treat the patient. So if we know that the patients, if we have somebody who wants to go for some medical checkup, we know that he has to move here and there, trying to contact different specialists. But we have all these specialists under one roof, and all the patient has to do is just take up our health package program and we'll get all the specialty services available to him. We also have the facility of investigations right at that very place itself, the radiological investigations, the lab investigations, etc. Everything done in the same hall. And then we have a specialized geriatric physiotherapy department, which is a part of this geriatric package. And at the end, the comprehensive geriatric assessment committee looks into the all-round holistically to the patient situation, and then decides the final treatment of the patient. So we follow ICOP, as we know that ICOP is designed to support community and primary care workers to assess health and social care needs of older people and design a personalized care plan in 3 steps. Yes, we are doing screening of the patients, we are assessing the patients holistically, and then we develop a care plan holistically as a team. So this is our geriatric assessment, comprehensive geriatric assessment pro forma, where a patient undergoes internal medicine or general medicine consultation, general surgery consultation, orthopedic consultation, cardiology, neurology, psychiatry, gynecology consultation for females, ENT consultations, ophthalmology, and physiotherapy. This is the comprehensive geriatric assessment team, which looks at entire thing at the end, which consists of a physician, pharmacologist, physiotherapist, and a dietitian. One of the most important part of our team is a clinical pharmacologist in the team who looks and who tries to reduce polypharmacy in the polypharmacy, because the patient has been going to multiple consultants using a lot of medicines, and to control this polypharmacy, we have a clinical pharmacologist in our team, and this is the final assessment and the comprehensive treatment plan which is given to the patient. If needed, we admit the patient. If needed, we call them. We have a follow-up of the patients, and this goes on. So the strength of our services, the personal care attendant given to one and all the patients right from the registration desk itself. So throughout the entire journey into our geriatric department, every patient is accompanied by an individual personal care attendant. We have entire care under one roof, rather one floor of my hospital. We have the pharmacologist, physiotherapist, and nutritionist in the team. Usually when we look into the health packages that are offered elsewhere, we hardly see all these people into the team. We may have all medical consultations, but pharmacologists, physiotherapists, and nutritionists are not present in the team, which we have it in our team. And we follow the integrated care for older people. That is the ICOP approach. So what does a clinical pharmacologist do at my place? We all know that multiple medical consultations means more medications and polypharmacy. There are going to be drug interactions with the other drugs and food, and that is what is being analyzed by the clinical pharmacologist at the end of the entire checkup program. And then he or she explains about the drug dosages, route of administration, and of course tries to reduce as much drugs intake, medicine intake as possible. Frailty increases with age, and it is a common clinical syndrome which we see in older adults, where there is a risk of poor health outcomes, including fall, incident disability, hospitalization, and mortality. Older people have, after a certain age, tend to get unintended weight loss, sarcopenia, that is loss of muscle mass, fear of fall, declining walking speed, reduced muscle strength, decreasing physical activity. All this happens because of aging. The eating habits change. They eat lesser than what they need. They are not in a position to cook properly for themselves, and hence they all end up into nutritional deficiencies. And this is where we have a nutritionist also into our team to take care of all these nutritional problems and reduce frailty. So if we look at ICOP implementation framework, we are right here because we develop person-centered goal and maximize intrinsic capacity and functional ability of the patient. So this is the goal of geriatric department of SVP hospital. We know that as the age advances, the risk of fall increases, and many elderly fall, and that is one of the major cause of mortality in across the globe. Now, fall in elderly is because of joint instability and muscle imbalance, reduction in joint range of motion, reduction in ability to ambulate properly, deficiencies in lower body strength, side effects of the medicines that the patient has been taking. With aging, there are going to be certain chronic diseases like arthritis, etc., and of course the neurological conditions. And all these problems are addressed by a specialized geriatric physiotherapy department. So, geriatric physiotherapy department is a part of health checkup program for geriatric department, which is one of its type, which we usually don't see anywhere. So here, our patients are assessed for functional range of motion, mobility, fitness, frailty, neurological problems, cognition, and sensory problems. Again, we try to maintain the functional capacity of the patient. So with the age, there is declining capacity, and if this is not addressed at the right time, there is a loss of capacity. So we, as a physiotherapist, try to develop the intrinsic capacity and functional abilities of the patients. Right, and this is the primary goal for the geriatric physiotherapy department. So what we do? Once if in our health checkup or in our physiotherapy checkup, we feel that the patient needs care, we try to call that patient to undergo physiotherapy sessions. And what we offer fitness training in them to develop their endurance and fitness under telemetry monitoring. We also have virtual and augmented reality system to address their balance, cognition, and movement impairments. We give them functional training to strengthen the muscles and to work on the muscles and improve the muscle power. We also have biofeedback training. Now, with age, joint degeneration is very common and they may have pain. So we have electrophysical modalities to address their pain. We have developed this special walkway. This is a specialized walkway, which is, these are mats of different textures. We want to address the proprioceptive and sensory issues. And this is where a walkway, this continuously gives the sensory and proprioceptive input, and that is how we develop. So we have a specialized place where we develop, where we work on the gait, balance, proprioception and coordination training for the patient. This is a kind of, this is coordination exercises going on for the patient. We also conduct group classes for this elderly, and they enjoy these group classes a lot, where we have chair aerobics, yogas, and specially designed group exercise programs for them. This is our studio, and this is a skid-free studio, so there is no fall. I mean, the tiles are such that it prevents fall, or it does not let the elderly fall down. We have so far, because we have just begun, this geriatric department began in March 2021. So we just 1 year, and we had a pandemic in between. In spite of that, we are lucky enough to have at least 300 to 500 patients in our OPD. And we, with the mean age of 68.04 plus minus 6.13 years. If we look at the values that we have got in our assessment, that is mean of arm curl test, chair sit to stand test, fall efficacy scale, short physical performance battery, mini mental state examination, and instrumental activities of daily living, except for chair sit to stand, all the values fall within normal limits. And this chair sit to stand values, age matched values are a bit increased, which means they take a little bit more time compared to the normal values. The back scratch test and even sit and reach test were within normal limits. But what we found alarming was the presence of knee pain. So 48 people had got mild knee pain, 22 individuals had moderate knee pain, and there was one female who had come to us with severe knee pain. Now, this was a routine checkup, which means they were not referred patients for these pains are an incidental findings during our assessment. So yes, we are new, and we have ample of opportunities to strengthen our system and hence make India or make Ahmedabad fall-free elderly place. We are basically managed by Ahmedabad Municipal Corporation, and so the authorities are trying to create awareness about this department through multiple advertisements on all print and social medias and even the television medias. We have a future plan, because in India what we have seen is, as age advances, people try to become sedentary. They accept their disabilities, they accept their problem because they attribute it to their age. This is of course changing, but it is going to take time, and we really need to create an awareness about how to be functionally independent, how to improve the physical activity level. And for that, we plan to hold seminars and educate older people in the community, and of course encourage them to visit our department, take help of our services. We also plan to conduct yoga and laughing club sessions across the city. So this is a testimonial which one of our beautiful patients gave us.
Hello, I'm a young lady of 82, and I am being associated with the geriatric ward at the SVP hospital since the last couple of months, maybe a little more. Earlier also, I used to go to physiotherapists for my treatment, but once I came to this particular place, the geriatric ward of the SVP, it was something else. The attention there, the expertise over there, the friendliness over there, the atmosphere, everything was so very congenial that it made me feel very at home and comfortable, and I knew I was in good hands. I am extremely thankful to all the staff, especially Meghaben and Nehaben, etc., and everybody, starting from the helpers to the students and to the teachers. They are doing wonderful work, and I appreciate their effort in helping the elderly people. Thank you very much.
And this is our team who is working day and night to make our city fall free for elderly. Thank you so much for listening to me patiently.
Thank you, Dr. Shah. That was a very interesting account of a clinical setting integrated approach to management of falls as well as trying to prevent falls. Thank you very much for your presentation. And up next, we have our fourth and final guest speaker, Associate Professor Francis Batchelor. Thank you, my friend, for joining us. Francis is an academic and clinical physiotherapist with over 30 years of experience working with older people across community, aged care and hospital settings. Francis is the acting director of the National Aging Research Institute and Senior Principal Research Fellow, overseeing a research program focusing on falls prevention, physical activity, healthy aging, technology, dementia care, and health and aged care system evaluation. Thank you, Francis, for joining us.
Thanks very much, Alex, for that lovely introduction, and good morning and good afternoon to wherever you are around the whole of the globe. I'm really thankful to be presenting today, and I'd like to start my presentation by acknowledging the traditional custodians of the lands from which I'm presenting today, the Wurundjeri Woiwurrung people of the Kulin Nation. I'd also like to acknowledge the traditional owners of the lands and waters across Australia and pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen Generations. So falls in residential care in Australia and in other countries around the world are a significant problem. The term residential aged care is the term we use in Australia, but in other countries, it may be termed nursing homes, care homes, or long-term care facilities. And we know that the rates of falls are 2 or more times higher in residential aged care than for people living in the community. And it's estimated that approximately 50% of residents will fall in any given year, which in Australia equates to 95,000 people having at least one fall per year in a facility. And of concern is that the rates of falls in residential aged care are actually increasing year on year. And in fact, they're increasing faster in residential aged care than in the community, an average of 4% increase each year. Now, the potential reasons for this are beyond the scope of this presentation. Not all falls in residential aged care do result in injury, but I think we've heard already today in this webinar about some of the consequences of falls. So in the worst cases, falls are associated with morbidity and mortality. And we've all heard stories about the downward spiral that some people, not all of course, experience after falling, and for example, sustaining a hip fracture, which then can sadly lead to immobility and all the issues associated with that. And some people never regain mobility. So what should be done to prevent falls? Well, for community dwelling older people, we do have high quality, robust evidence that exercise, which obviously consists of strength and balance training at the appropriate dose. And I think Kim really spoke to that. And this is clearly set out in the Step Safely technical document. So yes, strength and balance training is effective in preventing falls. And I think, as Kim also mentioned, the implementation of this at a population level is another matter, which needs urgently addressing, but is beyond the scope of this presentation. But in contrast, there's relatively less research undertaken in residential aged care. But as we can see from meta-analyses such as the Cochrane Review, and also really nicely summarised in the Step Safely technical package, there are promising interventions, but the evidence is not nearly as strong as for older people living in community settings. I think what's encouraging is that we're also starting to see the emergence of some great studies that support the effectiveness of exercise interventions in preventing falls in residential aged care, such as the Sunbeam program from Jennifer Hewitt in Australia on the right-hand side of your screen. And this has shown that an exercise intervention consisting of high-level balance and moderate intensity resistance training reduces falls by about 55%. And this is great news and very promising for the future. But actually, we have some challenges within the current context of aged care in Australia. So in Australia, back in 2016, a whole range of shocking examples of substandard care, neglect and abuse were exposed within the residential aged care sector. And it was really shocking, I guess, for all of us in Australia and around the world. This led to the establishment of a Royal Commission into Aged Care Quality and Safety. And the terms of reference of this commission were to explore the extent and nature of substandard care and establish recommendations to truly reform the aged care system. And over a period of 2 years, the Royal Commission heard testimony from a number of people with examples in which falls led to some really awful outcomes similar to what I described earlier, but nonetheless shocking. Instances where following a fall, appropriate follow-up did not occur, immobility ensued, and then we saw things like terrible skin breakdown and pressure areas, infections, and then in some cases leading to gradual decline and death. And in many instances where you think these things could have easily been prevented. So you can imagine that within the context of hearing about all these negative consequences of falls, that there was really a public and industry perception that we really must do everything we can to prevent falls and that it's an extremely important safety issue. If aged care residents aren't safe, then our system is failing us terribly. So stemming out of the Royal Commission as well as other work, the Australian Commonwealth Government introduced aged care quality indicators for which the mandatory collection and reporting of data on each of the indicators that you can see on your screen came into effect in July 2021. Now, if you look at these indicators, in actual fact, they could be viewed as safety indicators, the minimum that you might expect in delivering care for what we might term our vulnerable older community. And you can see that they cover 5 major areas: pressure injuries, physical restraint, unplanned weight loss, falls and major injury, and medication management. And so within the context of the Royal Commission and the introduction of these indicators, this clearly provides, means that providers of aged care services have incentives to implement practices that really drive down these numbers, and even to the point of aiming for zero, which seems on the surface or on face value quite reasonable and the right thing to do. And so what happens is when we have indicators, we have strategies that are put in place. So these may or may not be evidence-based. And then we are trying to achieve a desired impact with those potential strategies to really address the indicators that are being measured, because that's how performance is measured. So what we see with falls and major injury in this table is that there are a range, and I haven't included everything, but there are a range of different types of strategies, which again are implemented to a lesser or greater extent, such as exercise, vitamin D, hip protectors, gait aids, and the like. And we also see widespread use of sensing devices, so technology and alarms that detect movement and falls, as well as provision of supervision for movement and mobility and use of various types of equipment. So all of these are really trying to have a desired impact to reduce falls and injury, to improve strength and balance, and to reduce, yes, the chance of injury by improving bone health. But one of the particular issues in residential aged care is that falls risk is non-linear. So those who are independently mobile have a relatively low risk of falls because they're up and about and walking independently. But for those who may be able to get out of a chair but need supervision or assistance with mobility, they have a higher risk of falls. And in residential aged care, as people deteriorate and because of your comorbidities, such as things like dementia, at some point, residents may not be able to get out of a bed or chair, and therefore falls risk subsequently declines. So we have the issue of this middle group with the highest falls risk, where they have the need for supervision to mitigate that falls risk, but also limited resources in terms of staffing to provide that supervision. So what we have is that combination of a really strong desire to prevent as many falls as possible within the context I've already described, and strategies that are implemented to really try and reduce those falls, but often have unintended consequences. So what we see with that implementation of bed and chair alarms and smart floors is really a strategy to alert staff on the floor that someone might be moving. And then what happens is that staff potentially stop that person from moving until safe to do so. And what this has the unintended consequence of is that over the longer term, the potential to reduce mobility. And this message of not moving, of waiting for supervision can permeate. And I think while some of the strategies to address the other indicators may also have unintended consequences, fundamentally, I believe falls are different because as humans moving around in gravity, there'll always be some residual risk of falling that we cannot ever completely eliminate it. So this idea to aim for zero falls, I don't think is 100% desirable nor achievable, particularly within a residential aged care setting. Now, we also have a context in which our aged care quality standards place person-centred care at the centre, with standard 1 highlighting consumer dignity and choice in the circle right in the middle. And this can be particularly tricky in residential aged care, where we have providers who, of course, have a duty of care to provide a safe environment for our residents, but we have residents who are highly likely to have cognitive impairment or dementia, but may choose to undertake risky activities or have certain preferences. And added into the mix, we have families with particular expectations that facilities will keep, our loved ones safe. how do we balance all of these aspects within the context of the aged care broader environment, as I've alluded to in the previous slides? And there's no easy answer. And in fact, there are probably more questions than answers. So if we think about falls prevention in residential aged care or care facilities, are the very things that we implement also limiting residents' choices and preferences in them being able to move in their environment? For example, going outside. Are some of the things that we implement really disguised restraint? How does the data we collect as part of quality indicators take people's choice into consideration? So those quality indicators measure falls and injury, but they don't really measure the extent to which a person has chosen to undertake risky behaviour. It's all focused on driving falls to that 0 level. So staff can implement as many strategies as they like, but someone may still choose to take a risk. And what are the expectations of families, and how can we better manage them? So do regulations and standards do more harm than good? Well, the answer is no. We definitely do need regulations and standards and clinical indicators, but we also need to be aware of how they drive practice and be aware that they need to be carefully crafted and implemented with nuance, and that sometimes additional standards and indicators may be needed to ensure that aged care providers aspire to high quality care. And I think that within Australia and hopefully around the world, this is gaining traction. And there's certainly work underway to supplement mandatory clinical indicators with other indicators that will be helpful. And so whichever strategy is chosen with the end goal of preventing falls, we also need to consider how that impacts on stopping people from moving. So I think whenever we talk about falls prevention in residential aged care, what we need to do in the same sentence is also highlight that it should be falls prevention and maintenance of mobility, or even improvement of mobility. So what I wanted to do now briefly was just to provide an example of some of the research we're undertaking through the National Ageing Research Institute here in Australia that embodies this idea of falls prevention and mobility maintenance and improvement. And this is the Enjoy program of work led by Professor Pazit Levinger, which aims to promote public health by combining changes to the built environment, which is through installation of these senior exercise parks, with physical activity promotion. The seniors exercise parks are usually installed in local government areas and often co-located with community facilities and in close proximity to children's playgrounds. So really highlighting that intergenerational aspect and social connection. And they're outdoor stations designed for older people to improve balance, strength, functional movement, flexibility and mobility, and suitable for a range of abilities. And what we've found in a randomised controlled trial is that providing a supervised exercise environment and the opportunity for people to use the equipment themselves, that we've found that to be effective in improving balance, gait, physical activity, social connection and quality of life. So that was the first stage of research in this program of work. And in our recent study, some of the results which have been just published this year, in a pragmatic trial, we looked at a 12-week program of supervised exercise sessions at a seniors exercise park, followed by 6 months of maintenance phase where people were able to exercise themselves at a time of their choosing. We demonstrated that the intervention was associated with reduced falls and reduced falls risk, as well as improved balance and mobility. So incorporating both of those elements of falls prevention and mobility improvement were vital. And we could see as a result of the use of this type of approach. Now, these initial projects were undertaken with community dwelling older people, but we're also currently undertaking a project in which an exercise park is co-located with an aged care facility, a residential aged care facility. And we're examining the impact of a supervised exercise intervention with residents who have dementia. And here again, we're looking at those dual issues of falls and that mobility maintenance. So not just falls prevention, but enhancing mobility. So yes, stay tuned for the results of this particular research project. We're also extending the Enjoy project out to a hybrid implementation trial in which the exercise parks are really embedded in municipal local government areas, and that the communities themselves have a really big role in rolling out the programs, and so that it's sustainable for the future in maintaining physical activity, preventing falls and enhancing social connection. So I think we have a lot to look forward to. We've got innovations in terms of implementing new types of exercise programs in residential aged care that focus on maintaining mobility and preventing falls. And we already have evidence on interventions that really raise the bar, such as the Sunbeam program, which is being rolled out and evaluated within aged care in Australia. And finally, I'd just like to leave you with a quote from the Australian Aged Care Royal Commission's final report, which I think we can apply this sentiment to how we approach falls prevention in residential aged care. We can have organisations and systems goals which can be measured against standards and compliance, but our aspiration really should be that whatever we do, we should ensure that falls prevention and the maintenance of mobility incorporates the views and choices and preferences of those receiving aged care, their families and advocates. Thank you.
Thank you, Frances, for your presentation. So this concludes the formal presentations of our 4 guest speakers. In summary, I guess we've tried to align some presentations to give examples of community, clinical and regulatory approaches to falls prevention. Some examples in high-income country as well as low-income countries. And we hope that you might find alignment of these examples with what Step Safely tries to advocate, which is a systems approach to falls prevention using 3 domains of people, environment and policies. And so I now invite Dr. Caroline Lukaszyk to be the moderator of our open discussion. And I please encourage you to put your questions in the Q&A chat or raise your hand on your screen. Dr. Caroline Lukaszyk is the Technical Officer for Prevention of Violence, Injury and Harmful Use of Alcohol in the Social Determinants of Health Department of the WHO, based in Manila in the Philippines. Thank you, Caroline. I hand over to you now.
That's excellent. Thank you very much, Alex. And first and foremost, I'd like to thank everyone who participated today in this webinar. It's excellent to see so many people online, to see the diverse range of countries people are dialing in from, and also to see all the excitement and activity in the chat and in the questions. It's an excellent opportunity to connect, to discuss the Step Safely technical package, support its rollout, its uptake, and hear from experts in our field around preventing falls among older adults. And again, we are very, very pleased to have our 4 excellent experts joining us, again, from across the world. And without further ado, we do have around 15 to 20 minutes reserved for some discussion with our 4 panelists. And I wanted to kick off the session with a more general question that I hope everyone could supply an answer to. We've heard a lot about looking at these larger national programs, policies, strategies, programs. And what the question I have around here is, what are the largest barriers you have encountered to trying to expand or scale up falls prevention approaches across your communities? And this sort of also builds on Alex's question to Dr. Lele about how a national direction is really implemented at that community level. So not only barriers, but I'd also be interested to hear about what's really helped and supported you do this. So perhaps maybe I can first start off with Dr. Lele.
Hello, Lele's here, but I think I missed some words because of the internet. So what's the question?
Not a
Can you hear
problem.
me?
So Dr. Lele, the key
Okay.
question, how are national directions implemented at the community level? So how are your national strategies? How are you able to translate and implement those at the sub-national or even provincial level?
So thank you for the question. I think it's a very good question for to implement the community-based falls prevention for the older people. So I think in the policy health sector, from health sectors, there's primary care policy for the whole country from national level to it's a policy to from the national level to the bottom. There's a very important item, name is elder falls prevention item. So there's an item there, but because older people falls prevention there's a not a very long time research or implementation in China. So under the item of this primary care policy, there's not very specific strategies and specific measures in this national level policy. So what is the direction, or what is the next step for the community-based elderly falls prevention? Just from the practices and the experiences from different sectors, not only health, but also other sectors such as civil affairs and all sports, and the not only disease control, but also medical management sectors. They were working together to input all the elements or the measures or the strategies in under this item and promote that and scale up them to all over the China. So I think what the outputs from China CDC, just one perspective, not all China. I think there's many other sectors we're working together to scale up the experiences and the outputs of the practices to towards the direction.
Thank you very much, Dr. Lele. It sounds as though multi-sectoral collaboration is key in this regard. Dr. Meddings, I see your hand is up. Would you like to contribute?
Yeah. Thanks very much, Caroline. And just wanted to say, first of all, really great presentations. I was very interested to listen to the work that's been done, and it's quite inspiring to see the range of different approaches that are being used, both sort of high tech and lower tech, culturally appropriate interventions. I guess what I wanted to, if I could layer on as part of the dimension to Caroline, to your question, I think we have to really think about sustainability of these programs as well. I mean, it's one thing to sort of have a clear idea of what the evidence base is for fall prevention and management in older people, to see that in some settings there are effective approaches being adopted and used with success. That's all great. But I do fear that we sometimes will see sort of a modicum of success that is then undone by virtue of something as simple as a key champion moving out of the program, or a single line of government funding being withdrawn or repurposed. So I guess I'm feeling that in addition to the aspects that you have raised, Caroline, it would be interesting to hear our speakers talk about the issue of sustainability and how we can ensure that falls prevention programs are being structured in a way that they are sort of inherently resilient to all of these other factors that might work to undermine them. And I will also just take this opportunity to say thanks very much for the work, but I will have to sign off because I have another meeting at 9 o'clock my time, and I have to desperately prepare a bunch of stuff for it that I'm not ready for. So I'm sorry for that, but thanks again very much, and I'll leave shortly. Thanks.
Thanks so much, David. Another very important question that we can discuss in a bit more detail. I can see Associate Professor Batchelor, you have your hand up. Over to you for contribution.
Thanks, Caroline. One of the major barriers, I think, in this area is actually ageism and the fact that we know that falls cause more deaths and more injury than things like transport accidents, which is a key kind of topic of conversation in Australia. Yet it doesn't seem to get as much prominence in the policy field. And I think the work that's being done with the technical package is going a long way to helping address that kind of thing when you're positioning it again with, you know, falls in the work setting and falls in children. And I think we need to really embed that and bring that to the attention of the local, state and federal policymakers.
Yes, absolutely. Visibility is critical. And for that, we need high quality data that's presented in a very understandable and relatable way. So absolutely a priority. Professor Delbaere.
Yes, thanks. I totally agree with what Francis was saying, and also to avoid like the loss of the champions, you know, that they play a crucial role. It's important to have like a policy, a more national wide policy, so that we avoid all these individual kind of initiatives. They are excellent and they're fantastic, and we absolutely need to foster them in every possible way. But they're also very vulnerable because they don't have funding, and it will fall apart without funding. And if we can have a more national, statewide policy that makes sure that is secured, the funding and you know, just the overall initiatives, I think we'll go a lot further. And Francis, I also want to just thank you for your comment about ageism, because I totally agree with that as well. It's something that I encounter in my work every single day. Using technology, 2 years ago, when the start of COVID, we moved everything in all our trials to telehealth. It's been one of the most wonderful experiences, and I'm so grateful that I've kind of been able to do this, because older people are absolutely capable, because that is something that I often hear, that older people are not capable to use technology. This is absolutely not true. There is a lot of open-mindedness to giving it a go, and we have received so many thank you messages as well, especially over the last 2 years, where older people feel the gratitude that they have had the opportunity, and now they explore using it in other means, like to FaceTime the grandkids or something different. So it's something that we all kind of need to kind of look into our own ideas and what we feel, and just be fully open-minded to this, because there's so many opportunities here to make a difference.
Thank you so much. And absolutely, Standing Tall is an excellent example of how this has actually practically worked, which is very excellent to share today with all of our participants. I wonder if I could pass over to Dr. Shah with this similar question around, first of all, around really about potential upscale. So Dr. Shah, I know this, your center is one of just a handful in India. And I wonder if there is opportunity for upscale or for transfer to other areas of the country, and also around sustainability and what challenges you might face around this.
So, yeah, we are actually facing a lot of challenges. I mean, you know what happens in India is people are accepting their age. So it has been into their minds that once we age, we become sedentary. Plus, we have a joint family system in India. So what happens is when they have caretakers at home, they don't want to do work. So it is really a challenge for us to keep motivating them to, of course, the time is changing, people are changing, mindsets are changing, we are into nuclear families, we are into old age homes, etc. But yes, there is a lot of awareness that needs to be created among this elderly, that we have to be active till we leave. And we have to, the physical activity level is definitely reduced among Indian elderlies. They don't have that awareness that physiotherapy can help them. We need to drag them more and more to come and take our help, and we are ready to help them. And that is the biggest challenge that we face. When we talk about the health packages, people are definitely concerned about their blood investigations, about their physician investigations, whether their reports are falling within normal limits or not. But where they fail is they don't want to see what is their mobility level, what is their physical activity level, what is can we improve into our fitness and physical activity, and that is where we need to create awareness. But that's the problem at the country level. So we are working towards it, and we will be working towards it. Thank you.
Excellent. Thank you. Thank you very much. We do have another question in the chat that was received a while ago from Subaji. It was directed at our Australian colleagues, but I think it's an interesting question for all panelists. And the question was, how does Australia or other countries design inclusive and responsive services to prevent falls among older people who are in difficult circumstances, for example, for ethnic minorities, for people experiencing homelessness, etc., who are outside of institutions? And what family and community supports are available, promoted, or mandated in these circumstances? Would anyone have any initial feedback on this question? Yes, Kim, hi.
Yeah, I'll give it a go. But there's many health service areas that have their own initiatives to address falls prevention in minority groups, but they're very much local. Is my understanding. So there is definitely room for improvement there, and it kind of goes back to the same comment I made earlier, to make this a bit more of a stronger national mandate would definitely go a long way here.
I can make a comment too, Caroline, if that's okay.
Thank you so
I
much,
think,
Frances.
yeah, there's a lack of inclusion of people from diverse backgrounds within the research. And I think we need to do that as a priority so that we can really understand and adapt interventions to different cultural groups so that they're appropriate and relevant. It's happening more and more, but we also need differentiated data, I think, on different groups, you know, within larger groups that will help us to drive interventions that are really going to be effective for minority cohorts.
Excellent, thank you. I can see Sivaji has responded too. So yes, thank you very much for your responses. As our final question, I see we have 10 minutes left of the session. I do know we do have some final agenda items as well, but I think this is a question that's very important and relevant to everyone. This is around targets, around national targets. So do you feel that having quantifiable targets for reduction in falls outcomes at a national level is or would be helpful in driving implementation of falls prevention strategies? And as an example, for example, a 25% reduction in fall-related hospital admissions in 2030 compared to 2020 as a target. And so again, all speakers, but especially Dr. Leila, I know there are national strategies in China around this that have very clear quantifiable targets. So I'm opening the floor to discussion.
Okay, so you mean the targets for the indicators of falls prevention? So
yes, correct.
Yeah, for falls prevention, just as showed in my slides, there's not a very specific action plan focusing on elderly falls prevention. So there's not very clear, specific indicator to show how to prevent elderly falls to how about the situation or the level of that. But in different policies such as the disability prevention and disability prevention action plan of the national one and others, there's mentioned to reduce or decrease the morbidity or mortality of the elderly force, but there's not very specific target of the policy of the national level policies. So I think the next step of just with the evidence, we show how effectiveness of our strategies and measures can prevent elderly force. We can we set a target of the elderly force prevention for a 5 years or a 10 years or a period of time. So by now there's not a very specific, clear and specific about. Thank you.
Thank you very much. And Dr. Shah, I wonder if you have any insights as well on national or subnational targets around fall prevention that India uses.
Well, I don't know about the targets, but if I talk to you about the research project that we did with the Monash University, Australia, which was regarding trauma in India, and the alarming results were we had more than 10% of deaths following trauma, and majority of them were elderly. So that was really alarming for us, and we need to work on that, and we need to develop falls prevention strategies in India, and that I guess calls to a lot of research which is still pending at this corner of the world. So we're looking forward, because we're looking forward to more researches regarding this arena, and we really wish to work forward towards it.
Excellent, thank you. And perhaps Francis or Kim, any final words around whether this would be a helpful thing to have at the national or subnational level in Australia?
Well, I'd like to see this increase that we've seen over recent years, a 4% increase in rates or whatever, that seems to be increasing. I'd like to see that plateau and trend downwards. But I'd also like to see any targets coupled with targets around physical activity levels and reduction in sedentary behaviour, because then I think we'll see real impact from programs.
Absolutely.
I totally agree with that. I've got nothing to add. It's well summarized.
Excellent. Well, thank you very much, everyone. I can see we have 6 minutes left of our webinar today. There are a number of questions in the Q&A and chat that we will collect and review and provide responses to post-webinar. But at this stage, I'd like to say thank you again and hand back to Alex.
Thank you very much, Caroline. If I could add a little humble comment from the perspective of my PhD research, which looked at international public health policies in the area of falls prevention among older people in the community setting, especially. I have found over 100 public policies targeting this space. And it was very interesting that part of my scoping review, I looked at the quality of these policies. Now, we couldn't look at the quality in terms of what did they implement, how did they go, what was effective or not. But I was able to benchmark the policies against international guidelines on policy development to see what is a good quality policy. And in a nutshell, my findings suggest that most of our international policies are not written in a way that spells out targets. They're not written in a way that prioritize interventions, and they're not written in a way that show clear leadership for the issue of falls prevention. And I think we need to address that. And I think what Professor Delbaere mentioned before, that we need champions in this space to raise the profile of falls prevention among our policymakers. And I think I challenge every one of us here today that we are all champions in this field. And it's up to us to walk up to our respective ministers to hand them on a silver platter the findings of our research, the findings of our trials, the infographics to demonstrate success. And as Dr. Shah showed, a consumer or an older person's testimonials of just how the intervention changed their life for the better. I think we need to speak to our policymakers much more to actually demonstrate some impact. And I guess to round off is, I hope that everyone who participated in this webinar today will become aware of the Step Safely package and how it and the evidence synthesis that supports it on the website of the WHO, how much of an important tool it is for us to use to advocate for falls prevention, especially among older people. So just a little plug there for some of the research that is going behind the scenes and as is emerging. If I could just take one, we've got 5 more minutes left for this webinar. If I could introduce Professor Richard Franklin, just to give a little promotion for the next major WHO event, which is the World Safety Conference in 2022.
Thank you very much, Alex, for giving me this quick moment after such a great presentation about falls, and really interested the conversation about policy and thinking about the impact that we want to have in the fall space is a really nice segue into what we're trying to achieve with the World Safety Conference, which is going to be in Adelaide in Australia in November. So Sunday, the 27th to the 30th of November. And part of what we're doing with that conference is having a whole range of workshops that are going to help delve in, be interactive, and hopefully come out with some greater thinking around some of these areas. And so we've got a number of falls workshops that I'm working through. But to give you a bit of a summary to where we're at the moment, we've had over 600 abstracts received, which is a really good response, and really strong across a number of domains, falls being one of them, but also road safety, drowning, workplace health and safety, children, policy, emerging issues as well, which will be interesting to see what we pull out of that. We've also had over 50 workshops to occur over sort of the 4 days. The conference will start on Sunday with a number of workshops. Leading into that, the international collaboration of injury statistics is also meeting in the lead up to the conference. Bloomberg is actually going to support the welcome reception on the Sunday evening, which is very exciting as we hopefully see lots of people travel across the globe and come to Australia to do that very scary thing and meet face to face post-COVID. Well, still COVID obviously going on, but kind of post the lockdowns that we've obviously had across the globe. We will have the workshops that will run throughout. We've got keynotes as per usual. So keep an eye on the website, which is worldsafety2022.com. Also follow us on Twitter, which is the @conf_safety to see what else is going on as well as part of it. We will be working towards making sure that, you know, there's some high income, some low income, some regional staff, some global work that's going on as part of it. We will be much more interactive. We've put a little bit more time into the lunch sessions where we're going to have launch of products. We're going to have the media awards as part of it as well, talking about what's been going on across the globe. So lots going on. Put it in your diary. Really excited to have a couple of things as part of our spotlight sessions. Falls is one of those as well, but we've also got them on children, workplace health and safety, drowning, road safety, violence as well. And so, as we've always done with these conferences, is in partnership with the World Health Organization, and we have a number of local partners, including the Public Health Association, the Australian University Safety Association, and the Australian Injury Prevention Network as well. So really excited about the conference. You'll hear more about it. Really, I'm just here to say, if you haven't put an abstract in, it is slightly too late, but let me know. Email us saying that you're still interested in the next few weeks. They're actually out for review at the moment, and people will start to know whether they've been accepted or not. If you're interested in doing a workshop, they're coming to a close, but again, send them through so we can have a look at what's going on there. Book your flights, book your time, come across. There'll be a whole lot of activities around the conference as per usual as well. For those that are interested in a riding retreat up in the hills, I'm organising that for the Friday, Saturday, Sunday afterwards. And we'll be out having a look around Adelaide and all things sort of Australia. So come to the conference, come and visit us, come and be part of the conversation that is injury prevention across the globe. And hopefully we will connect, reconnect and talk about injury and about how important it is. So thanks very much, Alex, for having me. Thanks very much for a great session today on falls. It's been really great hearing about what's been going on across the globe. Great to delve into China and India and in Australia to see the projects that are going on. And it's really exciting. Agree with everything that everybody said, that we need more around falls and falls prevention. So hopefully out of this, we'll see a lot more action, and hopefully that'll flow into the conference. So thanks for having me and wishing you all the best.
Thank you very much, Richard. And if I could please promote to everyone who's remaining with us just now for the last 2 minutes, I do encourage you all to join us for webinar number 2 on preventing work-related falls, as well as webinar number 3 on preventing falls among children, adolescents. And these are happening on Thursday, 21st of April and Thursday, 28th of April. And I hope to see as many of you there, or if you could pass on the advertising flyer to your colleagues and networks, because falls is a very diverse area across settings, across age groups, and we need all the collaboration in the world to tackle this issue. Just to finish off, thank you very much to all our guest speakers. Thank you very much to the organising team at the WHO and MUARC behind the scenes to bring this wonderful webinar together. Thank you very much to all the 133, I think I saw participants online from all around the world. Thank you very much for your engaged in discussion, and we thank you for your participation. Thank you.